Now, so three major components to evaluating a pituitary adenoma. One is imaging, two is visual fields, and three is hormone hypersecretion to look at whether it's functional or not. So let's start with imaging. So MRI is the imaging of choice. What is required is a T1 weighted imaging with contrast. The posterior pituitary normally lights up as a bright spot because of high phospholipid content. This is a normal finding. So if you don't find a posterior pituitary bright spot, then it is pathological. Adenoma is usually going to be visualized as hypointense in T1 and hyperintense in T2. How do I remember? 2 is more than 1. So 2 is going to be hyper, 1 is going to be hypo. Easy. Usually what is visible is a snowman shaped solid homogeneous tumor, and if it is small, less than 1 centimeter, even then it is important to rule out hormone hypersecretion. If it is large, more than 1 centimeter, before jumping to a diagnosis of adenoma, it is important to rule out all these non-adenoma causes. For instance, if there is bony hyperostosis, could be meningioma. If it is calcified and hypointense with mixed solid cystic components, could be a craniopharyngioma. If the T2 shows hyperintense lesion, then it could be a glioma. If it is ovoid and cystic with no cyst wall enhancement, then it could be a rat case cyst. So this is how it is seen. Here you are able to see the almost snowman shape of the tumor. This is how the pituitary adenoma is seen. Now, as I mentioned, the second important aspect when we approach a pituitary adenoma is visual fields, because it helps us to understand the extension and the mass effect around. So, the easiest way for a pituitary adenoma to grow is in a supracellular manner, and the first thing that it's going to encounter would be the optic chiasm. Now, we all know how visual fields work, and hence what happens when there is a chiasmal compression here, the patient is going to develop a bitemporal hemianopia. So that again is clear, because all the lateral visual field from both the eyes is going to be represented at the optic chiasm. Therefore, a chiasmal compression is going to result in a bitemporal hemianopia. Now, a post-chiasmal compression. So, post-chiasmal compression is beyond the chiasm. So, you have the visual field here. So, this is the eye. So, from the lateral visual field, the impulses fall here, which is carried and get crossed here medially. Similarly, impulses from here get carried and cross medially. So, this is why the lateral fields are knocked off in a chiasmal lesion. Now, what happens when there is post-chiasmal compression? Which is chiasm? Post-chiasmal means beyond the chiasm. Then what happens? There is homonymous hemianopia. So, this is the chiasm. So, beyond this, if there is a compression, let's say here there is a compression, then what happens? You are able to see that the right visual field is completely knocked for both the eyes. So, this kind of a picture is seen in post-chiasmal compression. So, everything from here goes into this optic tract, and again everything from here crosses and goes again into this optic tract. So, anything post-chiasm is going to result in homonymous hemianopia. Bitemporal hemianopia is a heteronymous hemianopia. Pre-chiasmal compression. So, there is going to be compression prior to the optic chiasm. Then what happens? There is going to be a monoocular temporal field loss. So, why is that? So, usually this is where the pituitary tumor is. So, if it is going to be pre-chiasmal, it usually affects only on one side. So, therefore, the medial field is spared, only the lateral field, the temporal field is going to be affected. So, a pre-chiasmal compression usually causes a monoocular temporal field loss. So, it's usually, if it is big on one side, completely monocular blindness, or monocular, only the temporal field is going to be, only this field is going to be lost. So, having understood the visual field defects, how do we approach hormone hypersecretion? Now, functional adenomas can present with various hormone secretion syndromes. What is acromegaly? Acromegaly is a syndrome of growth hormone excess. What is hyperprolactinemia? Hyperprolactinemia is essentially a condition with prolactin hormone excess, which can be seen in prolactin producing tumors, commonly called prolactinoma. And finally, Cushing syndrome, which can be seen with ACTH excess. So, when there is ACTH excess from the pituitary causing Cushing syndrome, is the syndrome of cortisol excess, then it is called Cushing's disease. So, these are the tests that we ask for to look for hormone hypersecretion. You need a prolactin, you need a insulin-like growth factor 1 to assess growth hormone excess, a 24-hour urine cortisol and overnight dexamethasone suppression test to first confirm the Cushing's, and if there is Cushing's, what do you do further? You do a low-dose dexamethasone test. This is only a screening for Cushing's. If the low-dose dexamethasone suppression test is positive, you do a high-dose dexamethasone suppression test. And only from the high-dose dexamethasone suppression test will you know whether it is a pituitary Cushing's or whether it is ectopic ACTH. Pituitary Cushing's is called a Cushing's disease. Now, and then you do a FSH, LH and a TSH and a free T4. So, in case of prolactin secreting tumors, the prolactin is going to be elevated. In case of growth hormone secreting tumors with patients presenting with acromegaly, IGF-1 is going to be elevated. In case of a pituitary Cushing's disease, 24-hour urine cortisol, overnight dexamethasone suppression test, all will be high. On the low-dose dexamethasone suppression test, the cortisols will be unsuppressed. In the high-dose dexamethasone suppression test, suppression will be there by 50%. So, that tells you by 50% or more, and that tells you this is pituitary and not ectopic. FSH and LH will be elevated, and TSH and free T4, usually if free T4 is high, you would expect the TSH to be low if the pituitary is under an intact negative feedback mechanism. But suppose the FT4 itself, the increase in the FT4 itself is a result of increase in TSH, then your TSH will be inappropriately increased. So, that should point towards an inappropriate TSH should always point towards a problem in the pituitary, because usually TSH goes hand in hand with T3, T4. By that, what do I mean? So, whenever T3, T4 is low, TSH should go up because of negative feedback. Whenever T3, T4 is high, the TSH should go down. If that's not the case, there is a problem in the pituitary. Now, how do you treat these patients? There are three important goals for treatment. One is normalization of hormone hypersecretion. 2, offer symptom relief. And 3, we will have to remove these masses. So, offer shrinkage or ablation of large tumor masses. So, these are the goals of our treatment. So, remember that we will have to balance two things. On one end, we will have to preserve the anterior pituitary function. At the same time, we will have to achieve tumor removal in a way that future recurrence is prevented. So, how do we offer medical management? For prolactinomas, dopamine agonists form the cornerstone of management. For acromegaly, we use somatostatin analogs. And for TSH secreting tumors, again, somatostatin analogs and dopamine agonists, both are going to be handy. TSH secreting tumor is not very common. And what are the tumors which are not amenable to medical management? ACTH secreting tumors and non-functioning adenomas are not amenable to medical management. So, for a prolactin secreting tumor, you have dopamine agonists. For growth hormone secreting tumor, you have somatostatin analogs. You can use both for TSH secreting tumor, but for ACTH secreting tumor and for non-functioning adenomas, these tumors are not amenable to medical management. Now, what are the indications for surgery? So, either pituitary apoplexy, which is an endocrine emergency, or features of mass effect. When I say mass effect, either in the form of visual field defects or cranial nerve defects or persistent headache. These are the indications for surgery. And the preferred approach is transsphenoidal. The most common side effect that is seen is transient diabetes insipidus. That also occurs only in as little as 20% of the individuals. Other less common side effects include cranial nerve damage, vision loss and CSF leak. Now, generally, tumor resection is actually preferred to entire total hypophysectomy. However, in a few instances, we will have to prefer total or hemihypophysectomy if the mass is not well delineated, if there are multifocal lesions, and if the remaining tissue is necrotic. That is when you will offer hypophysectomy over tumor resection. So, usually when we say surgery as a line of management, we refer to resection of the tumor alone. Hypophysectomy is preferred only if the patient has multifocal lesions, not very well delineated mass, and in case of necrotic mass. Now, radiation, what is the role of radiation? Only as an adjunct in case there is a residual tumor following surgery or to prevent regrowth of the tumor. Other options other than radiation include stereotactic surgery and proton beam radiation. Now, let's look a little bit in detail at each one of these hormone excess syndromes. We'll start off with hyperprolactinemia. Now, there are important physiological conditions which can cause increase in prolactin levels. So, two such important conditions are pregnancy and lactation. Pregnancy and lactation are physiological conditions of prolactin excess. Other causes of transient increase in prolactin include sleep, sexual orgasm, chest wall stimulation, trauma, nipple stimulation and hypothalamic damage. So, remember, because prolactin is going to be under inhibitory control of hypothalamus, whenever there is a problem in the hypothalamus, prolactin is going to shoot up because it's released from the inhibitory control. So, this is the most common pituitary hormone hypersecretion syndrome both in males as well as in females. A prolactin level more than 200 microgram per liter is generally seen with prolactinomas, and a prolactin level much lesser, less than 100 microgram per liter, we'll have to think of other causes. This, however, is more common and we end up evaluating these patients a lot. So, remember that a prolactin less than 100 microgram per liter can be seen with stalk compression because the inhibitory control of the hypothalamus gets cut off. Can be seen with drugs, particularly antipsychotics and antidepressants. So, if you have a patient on antipsychiatric medications, then the hyperprolactinemia, and if the patient has mild hyperprolactinemia less than 100, then it could be very well the drugs. Renal failure because of decreased prolactin clearance, hypothyroidism. So, as I mentioned, TRH will be high and TRH actually stimulates prolactin, just like how dopamine. So, from the hypothalamus, there are two hormones which act differently on prolactin. So, dopamine is going to inhibit prolactin, and this is the major effect. There is also a minor contribution by the TRH which is going to increase the prolactin. Therefore, in hypothyroidism, what happens? Because negative feedback is lost, TSH and TRH increase. Because TRH increases, the prolactin increases marginally. And finally, microprolactinomas. So, remember, whenever prolactin is less than 100, it may not be a prolactinoma. Sometimes it could be a microprolactinoma, but more common causes are either stalk effect or hypothyroidism or drugs or renal failure. Drugs and hypothyroidism very, very important and need to be ruled out before further evaluation. Now, prolactinoma is the most common functional pituitary adenoma. This accounts for as much as 50% of all pituitary adenomas. Now, plurihormonal can also be, prolactinoma can be part of a plurihormonal tumor. So, in which case, there is going to be a mixture of prolactin hypersecretion along with hypersecretion of either growth hormone, TSH or ACTH. This is more common in females than in males. Size usually correlates with the hormone level. So, the higher the hormone, more likely that the size is high as long as you are dealing with a prolactinoma. Microadenomas are usually less than 1 centimeter and there is not going to be any invasion. Macroadenomas are going to be more than 1 centimeter, often with invasion and with a prolactin level of more than 250 microgram per liter. They may present with mass effects, particularly in case of macroadenomas like headache and visual field loss. Now, how do we diagnose? Typically, hyperprolactinemia presents with this triad of galactorrhea, infertility and amenorrhea. So, we can call it the EGA triad. The infertility, galactorrhea and amenorrhea, this triad makes up hyperprolactinemia. In males, it can present with the same infertility, decreased libido and also vision loss if there is going to be mass effects. So, a basal fasting morning prolactin is what is preferred, and a normal prolactin is going to be less than 20 microgram per liter. If a basal fasting morning prolactin is more than 20 microgram per liter, then we have to look for other causes. More common ones are drugs and hypothyroid. As long as it is less than 100, then this is what you will do. You will check the TSH, could be hypothyroidism. You will look at the creatinine, could be renal failure, or you will look at the drugs, more commonly could be that. And finally, remember that it could also be stalk effect. So, look at the other pituitary hormones. But before you do all of this, remember that sometimes there can be false positive results. The prolactin may be very high in case of macroprolactinemia. Now, macroprolactins are aggregated forms of prolactin and they are going to be biologically inactive, but what they do is they falsely increase the levels of prolactin. So, keep that in mind. Sometimes when you are evaluating a very high prolactin level and everything else is normal, it could just be macroprolactin. Similarly, we need to keep in mind false negative also. A very high prolactin, let's say more than 1000 microgram per liter, because of assay artifacts, that's going to give you falsely low levels. So, whenever, let's say you are evaluating a macroadenoma and there's a high clinical probability that it could be a macroprolactinoma, then you are always ask for a sample in dilution. That will avoid this problem. So, how do you treat these patients? One of the foremost ways is to address the cause. So, let's say you have a drug-induced hyperprolactinemia, stop the offending drug. If you have hypothyroidism, treat the thyroid, supplement the thyroid tablets. So, treatment goals are going to be in 3 directions. 1, we have to achieve symptom control. 2, we have to achieve hormone normalization. And 3, reduction of tumor size. The mainstay of diagnosis with respect to reducing the levels of prolactin is going to be dopamine agonists. So, cabergoline and bromocriptine are the ones that are commonly used, and we give them for up to 2 years after tumor reduction and until normal prolactin levels have been documented for 2 years. What are the adverse effects? Adverse effects are with constipation, nasal stuffiness, insomnia and postural hypotension. So, this is going to be the mainstay of treatment. So, whenever you have a patient with a prolactinoma, so dopamine agonists can achieve significant reduction in hormone level and tumor reduction. Only if there is a failure of medical management or if the patient continues to be refractory to medical treatment, only then will we offer surgery. Or in case there are features of invasion in the form of mass effects. If the patient has persistent headache or visual field loss, then yes, we will have to offer surgery. Otherwise, but for mass effects or refractory nature of the problem or treatment failure, the mainstay of management for prolactinoma is going to be dopamine agonists. The 2 medications that we commonly use are cabergoline and bromocriptine. So, having discussed about hyperprolactinemia and prolactinoma in particular, we will now move on to our next syndrome of hormone excess, which is going to be acromegaly. Acromegaly is the clinical syndrome of growth hormone excess. Now, the most common cause of growth hormone hypersecretion is a somatotrope adenoma. Mammosomatotrope adenoma and acidophilic stem cell tumors can present with growth hormone and prolactin hypersecretion together. So, these are these plurihormonal tumors. Other combinations of hormone excess may also exist. Sometimes you may have a growth hormone secreting adenoma, but when you image the patient, the cella may be empty. So, sometimes remember there may be an ectopic pituitary tissue and this somatotrope adenoma may arise from this ectopic pituitary. So, remember, whenever, although the most common cause of a growth hormone hypersecretion is going to be pituitary adenoma, whenever on the MRI the pituitary appears normal or you have an empty cella, remember there could be a ectopic pituitary tissue or there could be ectopic growth hormone secretion itself from a malignancy as part of a paraneoplastic syndrome. Sometimes there could be a ectopic GHRH secretion which could also cause hyperplasia of the pituitary, making the whole syndrome look like a somatotrope adenoma. So, keep that in mind. All these carcinoids can present with ectopic GHRH secretion. CA pancreas, lungs and ovary can present with ectopic GH secretion. Sometimes in the nasopharynx there may be a rim of ectopic pituitary tissues from which this somatotrope adenoma can arise. So, keep all this in mind. But the most common cause is a pituitary somatotrope adenoma. Now, how do these patients present? Usually, they have a very long time from onset to diagnosis, about 10 years. This is how the patient typically looks like. So, they have frontal bossing, increased hand and foot size. This is one of the common complaints from most of the patients. So, they say that they have to keep changing their shoe size ever so frequently. So, one of their major complaints when they reach a physician is that the shoes no longer fit beyond about 6 months or so, and they have to keep changing the shoe size ever so frequently to higher sizes. Then prognatism, mandibular enlargement, acral bony overgrowth, large fleshy nose, which gives this specific facies with frontal bossing, fleshy nose and prognatism, coarse facial features. In addition, there may be other features like proximal myopathy, acanthosis nigricans and other features of insulin resistance, carpal tunnel syndrome, kyphosis. So all of this can be there. So remember, growth hormone acts in an opposite manner to insulin. So they can present with features of insulin resistance. In addition, these patients, 3 complications are very common, and they are the 3 C's. So cardiac complications from coronary artery disease all the way to cardiomyopathy and arrhythmias are common. Central sleep dysfunction, obstructive sleep apnea is common, and colonic polyps and malignancy may occur. These are the 3 important complications that we need to keep our eyes open for whenever we are dealing with a patient with acromegaly. Cardiac problems from coronary artery disease to cardiomyopathy to arrhythmias, then colonic polyps and malignancy, and central sleep disturbances and OSA. How do you diagnose these patients? Screening is with serum IGF-1 levels, and if it is high, you will confirm it with oral glucose tolerance test. Now, this is a suppression test. So, as I told you earlier, all these hormone excesses will have to be confirmed by a suppression test. So, what you do a oral glucose tolerance test, and in 1 to 2 hours, you check a growth hormone. The growth hormone level should be suppressed. It should be less than 0.4 microgram per liter. That is the normal response. But if you don't have that, if the growth hormone is still above 0.4 microgram per liter, that tells you that the growth hormone is unsuppressed, and that confirms the diagnosis of acromegaly. So, screen it with IGF-1 level and confirm it with oral glucose tolerance test. For acromegaly, in contrast to what we learnt about prolactinoma earlier, surgery is going to be the initial treatment of choice. Now, medications are largely reserved either for symptom control or whenever surgery is not feasible. So, what are the options available? You are going to use somatostatin analogs as they decrease the levels of growth hormone. So, either daily octreotide or monthly somatostatin or lanreotide can be used. GH receptor antagonists have also been approved. So, drugs like pegvisomant are GH receptor antagonists, and they act at the receptor level and they control the effects. So, because they act at the GH receptor level, even with pegvisomant, there is going to be a decrease in the IGF-1 levels. And finally, dopamine agonists can be used in conjunction with octreotide. Radiotherapy is used as a last resort as an adjunct to surgery when patients are either intolerant to or do not respond well to the medical management. So, as far as acromegaly is concerned, find the tumor and knock off the tumor. Surgery is the mainstay of treatment. When surgery is not feasible, or preoperatively if you want some amount of tumor shrinkage or for symptom control, that's when you offer medical management. Medical management is predominantly with somatostatin analogs like octreotide and lanreotide, and pegvisomant is a growth hormone receptor antagonist which has also been approved for the same. So, I know this flowchart looks highly complex, so let's quickly break it down and make it easier. Now, whenever you have a growth hormone secreting adenoma, as I said, the treatment of choice is going to be surgery. So, surgery is going to be the treatment of choice. And when you've decided for surgery, you're going to measure the growth hormone and the IGF-1 levels. If they are high, to offer reduction in symptoms from growth hormone excess, somatostatin analogs may be added and the dose may be optimized. So, once you start off with a somatostatin analog, you can keep increasing the dose. If still desirable effects are not achieved, then what you do, you go up and add a GH receptor antagonist, which is pegvisomant. And then finally, you can add a dopamine agonist. That's how it generally works. So, if surgery is not an option, if surgical cure is unlikely, then you straight away start the patient on somatostatin analog, measure the IGF-1 and the response, add on increase the dose and add on pegvisomant, still no response, add on dopamine agonist. So, this is how you essentially work through the management of acromegaly. So, from this it is very clear that surgery, yes, you treat the patient with surgery, and if there is growth hormone excess, you add somatostatin analog. If surgery is no, this is surgery plus somatostatin analog. If surgery is no, you directly start off with medical management, somatostatin analog. Both these patients are going to be reassessed with IGF-1 levels, and depending on the response, you are going to increase the dose. So, increase the dose, 3 options. Add pegvisomant, Even then no, you can add dopamine analogs. So this is dopamine agonist. This is how you approach management of acromegaly. Now, having understood acromegaly, let's learn about Cushing's disease. We'll be talking about the various manifestations of Cushing's patient in detail when we discuss about adrenal disorders, but quickly here. So, what is the most common cause of Cushing's disease? So, when I say Cushing's disease, it refers to a pituitary tumor which secretes ACTH in excess. Usually a corticotropic adenoma, which are usually microadenomas and more common in females, which results in Cushing syndrome. Cushing syndrome is when there is a compatible clinical feature, a moon-like facies, buffalo hump, purplish striae in the abdominal wall, proximal myopathy, osteoporosis, impaired glucose tolerance, increased blood pressure. So all of this along with cortisol excess. This is the Cushing syndrome, right? So when you have a patient with Cushingoid features, the most common cause is not this Cushing's disease. Cushing's disease is one of the causes of Cushing syndrome. The most common cause for Cushingoid features is actually iatrogenic steroid intake. Other causes for Cushingoid features include either an adrenal adenoma or adrenal hyperplasia, which secretes Cushing's and is a cause for endogenous Cushing's. Other extraadrenal causes means the ACTH dependent. So, basically what we do whenever you have a patient with Cushing's syndrome, that Cushing's syndrome is essentially a clinical diagnosis. So, as I said, when a patient has all these features, then the first thing to rule out is iatrogenic Cushing's or an exogenous Cushing's. So, you do a 8 AM cortisol. If your 8 AM cortisol itself is suppressed with Cushingoid features, then it is exogenous Cushing's. If that is not the case, then it is endogenous Cushing's. In that case, it could be ACTH independent when the problem is going to be in the adrenals, or it could be ACTH dependent. So, ACTH independent ones are going to be characterized by suppressed ACTH, whereas ACTH dependent ones, the ACTH is not going to be suppressed. ACTH dependent ones, the problem could be the ACTH could be coming from the pituitary, which is called the Cushing's disease, which is what we are discussing, or there could be an ectopic ACTH secretion. So, this is how typically a Cushingoid patient presents with. So, moon facies, buffalo hump, obesity, central obesity, abdominal striae. In addition, there will be proximal myopathy, purpura, skin ulcers, osteoporosis, emotional disturbance, mood disorders, cardiac hypertrophy, all of this. So, from this chart, we are able to see that the more common features include obesity, moon-like facies, hypertension, purplish striae, menstrual abnormalities and abnormal glucose tolerance. These are the more often reported clinical symptoms. Whenever a patient has hyperpigmentation or hypokalemic alkalosis, always remember that likely that this patient has ectopic ACTH. Alright, so whenever patient has hyperpigmentation, hypokalemic alkalosis and hypokalemia, these two hypo and one hyper, likely that you are looking at a ectopic ACTH driven Cushing syndrome. So, why is this the case? Because of increase in ACTH, there is an excess of ACTH and that sort of overflows and starts stimulating the mineralocorticoid receptors also. Because of that, you have hypokalemia, you have this alkalosis, metabolic alkalosis with hypokalemia. Now, when you take this increase in pigmentation, why is that? As I already said, whenever there is increase in ACTH, there is going to be increase in pigmentation, but because the level of rise in ACTH is to that extent with ectopic ACTH secretion as compared to pituitary, hyperpigmentation is more common, more profound in ectopic ACTH syndromes. So, the first test in a Cushingoid patient, as I mentioned earlier, first step is to see if it's exogenous or endogenous. So, you do a 8 AM cortisol. If 8 AM cortisol is suppressed, you are looking at exogenous Cushing. So, if this is less than 5, it is suppressed, then you are looking at exogenous Cushing's. If 8 AM cortisol is normal, increased or unsuppressed, then you are looking at endogenous Cushing's. So, you can screen with any 2 out of these 3 screening tests. So, you have a 24-hour urine-free cortisol, midnight salivary or serum cortisol and overnight dexamethasone suppression test. This is more convenient to do and it's easier to collect. So, this is what we generally do. So once you do these screening tests, if 2 out of 3 screening tests are positive, then what you do, you will have to confirm with a low dose dexamethasone suppression test. Even during the low dose dexamethasone suppression test, if the cortisol is unsuppressed, then a diagnosis of Cushing syndrome is confirmed. Now beyond this point, we'll have to find out whether it is ACTH dependent or not. So you do a ACTH. If ACTH is going to be low, then the problem is in the adrenals. So do a adrenal imaging. If the ACTH is going to be unsuppressed, then the problem could be in the pituitary or ectopic ACTH secretion. So this is where your high dose dexamethasone suppression test comes in handy. So if there is suppression to less than 50% of the baseline, if your cortisol levels suppress to less than 50% of the baseline, then that tells you that this patient has a pituitary Cushing. So this is a Cushing's disease. In that instance, you will have to do a MRI. Sometimes, as I mentioned, because these corticotropic adenomas are extremely small, it may be very difficult to be picked up on the imaging. So in such instances, an inferior petrosal sinus sampling will be helpful. Now, if inferior petrosal sinus sampling also shows discordant values and you have a normal, in such a case, the inferior petrosal sinus sampling will be helpful. Now, when you do inferior petrosal sinus sampling, this requires a lot of expertise. This is an invasive test. So, whenever the values are discordant, you have a normal MRI or a lesion less than 6 mm, that's when you do this. So, you give a corticotropin releasing hormone after ensuring placement of both the catheters in left and right inferior petrosal sinus. You check for a petrosal to peripheral ACTH ratio. If it is more than 2 at baseline and more than 3 at 2 to 5 minutes post CRH, then that tells you there is a Cushing's disease. Similarly, an ACTH gradient of more than 1.4 between the two sides helps in localizing the side of the tumor also. Now, during the high dose dexamethasone suppression test, if there is inadequate suppression of the cortisol, then the problem is ectopic ACTH secretion. So, you will have to hunt for the tumor with CT or PET-CT. So, how do you differentiate between pituitary Cushing's disease versus ectopic ACTH secretion? So, first and foremost, the important thing to keep in mind is pituitary Cushing's is more common in females, but ectopic ACTH secretion is more common among males. Generally, pituitary Cushing's will have a slow onset, whereas ectopic ACTH secretion, the Cushing's will have a rapid onset. Not only that, we saw earlier that ectopic ACTH is going to be associated with hyperpigmentation. It is also going to be associated with hypokalemia and metabolic alkalosis. So, as you can see here, serum potassium is usually low in ectopic ACTH secretion. So, in addition to that, you find that the basal ACTH level, it is not suppressed with pituitary, but it is extremely high in patients with ectopic ACTH secretion. The one which helps us in identifying which of the two it is the high dose dexamethasone suppression test. The cortisol is suppressed to more than 50% from the baseline, then it is pituitary Cushing's, because these cells still retain their negative feedback mechanism. That is the logic behind it. Whereas ectopic ACTH secretion itself is from a different source. Therefore, they are not going to be responsive to the negative feedback mechanism. Therefore, with high dose dexamethasone suppression test, there is inadequate suppression of the cortisol. Cortisol still remain high, and that tells you this patient has ectopic ACTH secretion. And finally, when you are still in doubt, you do a inferior petrosal sinus sampling and a sinus to peripheral ratio, petrosal to peripheral ratio. It has to be more than 2 for us to say at the baseline and more than 3 post CRH for us to say this patient has a pituitary Cushing's. So, how do we manage these patients? So, as I mentioned earlier, most of the ACTH secreting tumors do not respond well with medical management. So, surgery is the treatment of choice. We need to offer a transsphenoidal surgery. Remission rates are about 80% for microadenomas and 50% for macroadenomas. Now, in case the surgery is unsuccessful, we will have to offer hypophytectomy, removal of the entire pituitary itself, or radiation along with medications. So, what are the medications that may be useful in patients where surgery has failed or where surgery is not feasible? One is spesiretide. Spesiretide is a somatostatin analog which works more at the type 5 receptor rather than type 2. So, on this drug, about 25% of patients normalize cortisol levels and 40% achieve tumor shrinkage. Other drugs which are useful include ketoconazole, mifepristone. Ketoconazole is a P450 inhibitor. Mifepristone is a glucocorticoid receptor antagonist and approved for treating hyperglycemia in Cushing's disease. Metirapone and mitotane again are drugs which work through 11-beta hydroxylase inhibition and normalize cortisol levels. Other drugs like aminoglutamide, cyproheptadine and trilostane can also be used. These are the important ones to remember: pasireotide, ketoconazole and mifepristone. So, quickly let's wrap off the session by discussing about non-functioning and gonadotropin producing pituitary adenomas. Now, the non-functioning adenomas, these are actually the most common type of pituitary adenoma. So, the most common hormone hypersecretion syndrome is hyperprolactinemia, but the most common type of pituitary adenoma is actually the non-functioning adenoma. This is usually a macroadenoma at diagnosis and most of these arise from the gonadotropes. They can present with mass effect or with stalk effect or with other hormone deficiencies, and rarely they develop very large tumors and they can present with ovarian hyperstimulation or menstrual disturbances. Diagnosis is usually on the imaging. Some patients may have elevated gonadotropins with the FSH being more than LH, and often because they are large tumors who present with mass effects, they are going to be diagnosed primarily with MRI and visual field testing. However, these tumors, the cornerstone in diagnosis is going to be immunohistochemical analysis of the resected tumor tissue. Treatment, as I said, because these are macroadenomas and most often present with mass effects, they are going to require surgery along with radiotherapy and follow-up MRI scans at least once a year to pick up recurrence. TSH secreting adenoma, when we look at TSH secreting adenomas, these are rare, they are large and they are invasive. They are extremely rare. That's the first take home. If at all they do occur, they are going to be extremely large and invasive. So, they are going to present with features of secondary hyperthyroidism and a large goiter. Free T4 is going to be high and TSH is not going to be suppressed. So, you have an inappropriate TSH against a high T4. MRI shows a pituitary adenoma which is easily visible because most of these tumors are large. Treatment again is going to be in the form of surgery. If the patient has significant features of hyperthyroidism, we are going to treat the hyperthyroid state with antithyroid drugs and thyroid ablation. Somatostatin analogs can be a good option in patients in whom surgery is not feasible. They offer up to 50% tumor shrinkage, and in addition, we will have to offer thyroid hormone replacement as well. So, in a nutshell, whenever there is an acquired damage, so I have covered the length and breadth of pituitary disorders, particularly with respect to anterior pituitary. We will focus our attention on posterior pituitary in our separate discussion on diabetes insipidus. So, as far as pituitary is concerned, there are two ends of the spectrum. So, you have hypopituitarism and syndromes of hormone deficiencies associated with it, and then you have pituitary tumors which may be associated with syndromes of hormone excess. So, there are 6 anterior pituitary hormones. You have the growth hormone, the prolactin, the ACTH, TSH and FSH and LH. So, which is the hormone which is secreted by the most widely available cell in the pituitary? That is going to be the growth hormone, because somatotropes make up 50% of the pituitary, which is the hormone that is coming from a very tiny contribution, that is the TSH. Thyrotropes make up only 5% of the pituitary. Now, remember, whenever there is any acquired damage to the hypothalamus or the pituitary, the first hormone to be released is going to be the growth hormone. What are the causes of hypopituitarism? Remember DIVIT. What is DIVIT? So, developmental anomaly, be it pituitary dysplasia or hypothalamic dysfunction, I for infection like tuberculosis or toxoplasmosis or histoplasmosis, V for vascular like pituitary apoplexy, another I for infiltration like sarcoid or hemochromatosis, and we have 2 T's which are trauma and tumor, which are the more common causes. So, these are all the different causes of hypopituitarism and what are the tests that you do to demonstrate various hormone deficiencies. There are 3 tests to look for deficiency of 6 hormones. So, you have the insulin tolerance test which is going to assess the ACTH as well as the growth hormone reserve. You have the TRH stimulation test which is going to assess the prolactin and the TSH reserve, and then finally you have the GnRH stimulation test which is going to assess the LH-FSH reserve. Now, the most common presentation of adult hypopituitarism is actually hypogonadotropic hypogonadism. The most common cause of ACTH deficiency is actually iatrogenic. So, iatrogenic hypothalamo the most common cause of ACTH deficiency is actually iatrogenic. So, iatrogenic hypothalamo pituitary adrenal axis suppression secondary to long-term glucocorticoid intake and inappropriate withdrawal. When we look at the other end of the spectrum, which is pituitary tumors, pituitary adenoma makes up about 15% of all intracranial neoplasms, and not only that, this is the most common cause of pituitary hormone hyper or hyposecretion in adults. So, very important. So, be it pituitary hormone hypo or hypersecretion, pituitary adenoma is the most common cause in all adults. The most common type of pituitary adenoma is going to be non-functioning adenoma. They make up 1/3 of pituitary adenomas, but the most common type of functional pituitary adenoma is going to be the prolactinoma, and the most common hormone hypersecretion syndrome in adult males and females is also going to be hyperprolactinemia. Now remember, usually the non-functioning adenomas and TSH adenomas are going to be macroadenomas, whereas on the other hand the ACTH secreting adenomas are going to be very tiny. Usually they are microadenomas, other end of the spectrum. Now once you have a pituitary adenoma, the evaluation should be in threefold. One is localization and confirming the diagnosis. So, you need a MRI pituitary, you need a T1 weighted imaging with contrast, and remember the T1 T2 rule. 1 is lesser, so hypo, 2 is more, hyper. This is how your pituitary adenoma is going to look on the MRI. Second, for mass effect, the first thing that's going to happen, because there is least resistance against the dorsal cella, there is going to be supracellular extension and there is going to be chiasmal involvement. So, ophthalmological evaluation with visual fields needs to be done, and finally, we will have to assess hormone hypersecretion. How do you go about it? If the patient has features of the hyperprolactinemia triad, what is that? IGA, infertility, galactorrhea and amenorrhea. If they have this triad, likely that you are dealing with a prolactin secreting tumor. So, in such a case, prolactin is usually going to be more than 200 microgram per liter. If prolactin is less than 100 microgram, then you will have to rule out hypothyroidism, renal failure, drugs or stock effect. Rarely it could be a microprolactinoma. Most macroprolactinomas are going to have prolactin levels of more than 250 microgram per liter. Now, if you have a tumor with growth hormone hypersecretion, then screening test is going to be with IGF-1 and your confirmatory test is going to be with oral glucose tolerance test. So, for prolactin you are going to do only the prolactin. Remember to do a prolactin in a basal fasting morning sample, and if there is a likelihood that the level may be very high, if the patient has florid features of hyperprolactinemia, remember to order for it in dilution. So, second test is going to be an IGF-1. If IGF-1 levels are elevated, we will follow it up with a oral glucose tolerance test. On the oral glucose tolerance test, if the growth hormone is not suppressed above 0.4, then that tells you there is acromegaly. Then ACTH hypersecretion, we went through the whole algorithm of Cushing's. You start off with the 8 AM cortisol to see whether it is endo or exogenous Cushing's. Then you have 3 screening tests. At the end of it, you can only screen for Cushing's. So, you have overnight dexamethasone suppression test, which is what is commonly used, 24-hour urine cortisol and a midnight serum or a salivary cortisol. So, at the end of it, if there are at least 2 tests which favor Cushing's, then you will have to confirm it with low dose dexamethasone suppression test. So, low dose dexamethasone suppression test only helps to confirm Cushing's, but it is high dose dexamethasone suppression test which tells you whether this patient has Cushing's disease or ectopic ACTH secretion. So, if there is a more than 50% reduction, so if the fall is to less than 50% of the baseline, then there is pituitary Cushing's. So, essentially you go through the whole thing, but it is the high dose dexamethasone suppression test which tells you whether it is a pituitary Cushing's or ectopic ACTH. And finally, if you have a TSH secreting adenoma, doing a TSH, free T3, free T4 will tell you, because free T3, free T4 will be high and you will have an inappropriately normal or an increase in TSH. This is how the picture is going to be. I hope this session was helpful. Thank you. This is Dr. Adhiti for RAAONLINE.